Good morning. And once again, I would like to begin by thanking the organizers for inviting me to participate in this year's NeoCon and Evidence-Based Neonatology conference. I'm delighted to be here in Hyderabad, and I'm also grateful for the opportunity in the next 20 minutes to review with you the long-term benefits of neonatal caffeine therapy for apnea of prematurity. Now, when we're discussing these long-term clinical effects of one of the most commonly used drugs, or certainly the xanthines being the class of drugs that is most commonly used after antibiotics, the CAP trial features prominently. That's the Caffeine for Apnea of Prematurity trial. And the simple reason is that we owe almost everything we know about the long-term benefits of this therapy to the children and their families who participated in this trial and to our international investigators. Now, let's take a couple of minutes and step back into the last century. In the 1990s, when we were beginning to plan this trial, there was a rapidly growing body of evidence coming primarily from the bench and from experimental animals in several different species that were consistently pointing to the possibility of harm, the possibility of toxicity, of adenosine receptor blockade by this class of drugs, the xanthines, including caffeine, especially when a developing animal, a developing brain, was exposed to this medication. This body of evidence that was still growing and continues to grow, actually, was contrasted with a complete lack of rigorous evaluation of this treatment in our patients, in the babies, to whom we were already back then giving xanthines quite regularly, because one thing had been established, that in the short term, these drugs reduce the frequency of apnea and periodic breathing. So this state of uncertainty, of the possibility of harm coming from experimental studies and the lack of any meaningful evaluation of clinical outcomes in our patient population became the rationale for the CAP trial. Now, earlier this year at the PAS meeting in San Francisco, the CAP investigators celebrated almost 20 years of collaboration and friendship. Because in 1998, we first brainstormed the study question and then moved on very quickly to our first and successful grant application. And earlier this year, in 2017, we published the 11-year outcomes of participants in this trial. This slide shows you our original study question. We targeted as our population very low birth weight babies, but only up to 1,250 grams, who were at risk of apnea of prematurity, so targeting the babies at highest risk. And the comparison was use of caffeine compared with placebo, and the outcome was death or disability at a corrected age of 18 months. At this point, I always need to stress that placebo was used as a masking mechanism to make the trial more rigorous. It did not mean that infants in that group were not treated for apnea. They were treated for apnea with all possible means except drug therapy. And also you have to remember that, 20 years ago, we could still reasonably confidently say that you should just use CPAP or other respiratory supports to treat apnea if necessary, because the knowledge that this was very injurious was really only just beginning to be gathered. We enrolled the target sample size of 2,000 eligible babies over 5 years between 1999 and 2004, and this shows you the distribution of recruitment around the globe. This was very much a trial that was done in very highly developed tertiary care, neonatal intensive care units. And babies, the birth weights I've already given you, were eligible in the first 10 days of life if their local clinicians considered them to be candidates for xanthine therapy. So situations that included facilitation of extubation, treatment of actual evidence of apnea and periodic breathing, or also in very immature babies, prophylaxis. In 2006, we reported the short-term clinical outcomes of the participants in this trial, and this slide is sort of set up as a forest plot, but instead of the trials, you're seeing the individual outcomes, and you just look forwards to the left of one, the line of equivalence, and you can see that we showed quite convincingly that caffeine reduced the risk of BPD, bronchopulmonary dysplasia. It also reduced the risk of severe retinopathy of prematurity. These two outcomes very often travel together. And also, it was noted that caffeine reduced the use of therapies, both drug and surgery, to close a patent ductus arteriosus. However, we have no evidence that caffeine actually closes the PDA. Maybe it's just because babies were less long on respiratory support. They were not examined that frequently for a PDA. But the main outcome in the original trial was death or disability, as I showed you earlier in the PCOT question at 18 months. And caffeine reduced this outcome. In fact, it was the first and so far basically the only neonatal drug therapy that has been convincingly shown to have this effect. And among the components that made up this composite outcome of death or disability, you can see in the second line on this slide that there was absolutely not a hint of an effect on mortality. The point estimate of the treatment effect is basically on 1, but the effect on the composite came primarily from a reduction of the risk of cerebral palsy from over 7% in the placebo group to 4% in the caffeine group. Now, at 5 years of age, the observed rates of the outcome of death or disability, as you can see here, still favored the caffeine group, but the difference was no longer statistically significant. If you're going by the typical cut point of 0.05, although 0.09 is what our statistician calls an interesting p-value. Nevertheless, these reports, this report at 5 years led many observers, and you can read it in editorials and review articles that have been published since. This finding has led many people to conclude that caffeine was no longer effective at 5 years. We do not agree with this conclusion because secondary and one post-hoc analysis at 5 years consistently showed lasting benefits on motor function. I'll show you just a couple of examples. They were published but sort of buried in the main paper, and the abstract said no effect on the primary outcome, so that's what most people read. So, for example, here we have used the full ordinal scale of something called the Gross Motor Function Classification System, which is really an international shorthand way of describing the severity of cerebral palsy, especially in children. And you need to know that 1 is the mildest level of impairment and 5 is the worst. So 5 would be the children who would be wheelchair-bound at 5 years. And you can see that very clearly, when we analyzed the full ordinal scale of this measure, that caffeine at 5 years clearly reduced the severity of the motor impairment. Moreover, I think as pediatricians, especially as neonatologists, we have been slow to learn that cerebral palsy is actually, at least where it's studied in the West, is no longer the most important type of motor impairment after premature birth. Cerebral palsy rates are actually falling, and certainly the severity of cerebral palsy is typically less than it used to be 10, 20, 30 years ago. But there is something else that troubles these children, and we have been slow to recognize this, and that is something it's called developmental coordination disorder. This disorder does not get children into wheelchairs, but it is still a very disabling condition that affects things like balance and manual dexterity. So we had collected at 5 years all the information, all the data we needed to be able to assign whether a child had developmental coordination disorder or not. There are certain criteria. Explicitly, those children are not supposed to have cerebral palsy. So if you have a diagnosis of cerebral palsy, that child cannot have DCD. Equally, the child cannot have cognitive impairment, because once you have cognitive impairment, getting the motor system assessed obviously becomes a little tricky. So we did this one post-hoc analysis because we recognized, with the help also of our developmental experts on the steering committee, that this is a very important condition that we hadn't quite appreciated when we wrote the protocol several years earlier. So we did, with the leadership of Lex Doyle in Melbourne, this one post-hoc analysis of DCD in the children who were assessed at 5 years, and there were over 1,500 of those. And you can see here that there is a significant reduction of this type of motor disability by caffeine, in favor of caffeine. The rate's basically 15 versus 11%. Note also that those rates of motor disability are far higher than what we would have, double or triple what we would see for cerebral palsy. So here we are, 11 years later, and we added this latest phase of the follow-up to be able to do things with the children, to examine, to evaluate capabilities that we could not test at 5 years, to be confident that we continue to see benefit rather than harm. Because remember, the original justification for the trial was actually that we were concerned about the safety of the routine exposure of babies to this drug. As I said, the main outcome of this evaluation at 11 years was published earlier this year in JAMA Pediatrics, but there is more to come. We have other tests and questionnaires that we're still in the process of evaluating and writing up. The study question for this 11-year phase is shown here, again in the PICOT format. This time, English or French-speaking CAP trial participants only were eligible. I'll get to in a moment to the reasoning for this. Obviously, the treatment contrast remains the same, and we were interested in functional impairment at age 11 years. And this is 11 to 12 years was the assessment window. Now, what did we mean by functional impairment? With the help, again, of our developmental experts and child psychologists on the team, we chose a priori that would be functional impairment in at least one of academic performance, motor function, and behavior. And at the bottom of this slide, you can see the tests that were used to to test those 3 different domains. The Wide Range Achievement Test, 4th edition, Movement ABC out of the UK, 2nd edition in this case, and the Child Behavior Checklist, which is a parent-completed questionnaire. If you're interested more in this, in the psychometrics of this evaluation, this slide summarizes how we defined impairment. We basically followed the manuals and recommendations of those who had developed these tests. So for the RAT4, the Wide Range Achievement Test, a child was considered to have poor academic performance if at least one standard score in the 4 subtests was less than 70, that's less than 2 standard deviations below the mean of 100. Those 4 subtests are listed here. They are sentence comprehension, word reading, spelling, and math. In the Movement ABC, as recommended by the developers of this test in the 2nd edition, abnormal results were considered, or poor motor performance was considered present in those children who performed at or below the 5th percentile. The Child Behavior Checklist was considered to show disabling behavior if the total problem T-score was greater than 69. This test is normed a little different. That is 2 standard deviations above the mean of 50. So I had shown you already in the PCOT question that we restricted this assessment basically to English, mostly English, and in Canada also to French-speaking children. And that was for 2 reasons. Number one, we selected large centers that had shown little attrition at 18 months and 5 years. But the language restriction had a different reason. And that is that these academic achievement tests don't translate well. And you can imagine if you're testing for sentence comprehension and so forth, it's very difficult to do that across different languages. So in the centers that participated at 11 years after those restrictions that I just explained, there were 1,202 children eligible who we knew at 5 years had been survivors. And they were fairly equally distributed between the 2 groups. And you can see that essentially we collected adequate data to be able to assign the composite primary outcome with its 3 components to 77% of those children, or 920. So here then are the results for this composite that we called functional impairment at 11 years. And you have the same situation basically as we had at 5 years. The observed rates clearly favoring caffeine, but if you look at the bottom, p-value 0.07, the 95% confidence interval on the odds ratio does include 1. Just barely, but it does. Now, the next slide shows you the types of impairments that make up this composite, and for now, just please focus on the top and the bottom line, academic performance and behavior, and you can see that the rates were broadly similar, and there's not anything really going on in terms of differences between the 2 groups. However, caffeine significantly reduced the risk of motor impairment as measured with the Movement ABC. And if we went into the details of the Movement ABC, the effect came from the general performance score, from the balance score, and from the manual dexterity score, not so much from the 3rd subtest, which is aiming and catching. At the bottom, you can see that based on the frequencies that we observed in this sample of 920 children, the number needed to treat with caffeine in the neonatal period for apnea of prematurity was 13, with a fairly reasonable confidence interval, 95% confidence interval of 8 to 42. Note also, which is not shown on the slides, that of the 220 children, With motor impairment, only 50 had a diagnosis of cerebral palsy, pointing again to the importance of DCD. Can I carry on for a couple of... So, in conclusion, caffeine therapy for apnea of prematurity did not significantly reduce the combined rate of academic, motor, and behavioral impairments at age 11 years, but caffeine therapy reduced the risk of motor impairment, and we believe that we're quite confident, even though it was a smaller sample than the original one. It was only one component of the composite, so we have to be careful. But we believe we have seen it so consistently, an effect on motor function at 18 months, at 5 years, and now at 11, that we feel quite confident that this is a lasting benefit of caffeine therapy, which we believe we have now shown to be effective and safe into middle school age. And I'll stop here and leave the rest of what I plan to tell you for the discussion. Thank you.
I have a question about DCD and the motor impairment you're seeing later, which is not cerebral palsy. Is there an anatomic basis for that? Is there MRI data to say it's in the cerebellum or some other location?
Yes, cerebellum because of the balance, right? I'm not aware, to be perfectly honest, that there are such data, but I would not consider myself an expert in MRI. But in terms of the effect of the motor benefit, whether it's DCD or cerebral palsy, it seems to be doing both. It goes beyond the question you asked, Rich, but I think it's an important point I would like to get across. We obviously asked ourselves, how might one explain this motor benefit? And I don't know if you remember, but at the 18-month stage, quite some years ago, we had done a post hoc analysis to try and explain the treatment effect at 18 months, and we found that the postmenstrual age at which any form of positive airway pressure, so CPAP and intubation, both invasive and non-invasive positive airway pressure were last used, explained basically half of the treatment effect, which was enormous actually to have a single intermediate outcome, because that intermediate outcome was reduced by caffeine, and it explained half of the treatment effect at 18 months. So we did at 11 years one single post hoc analysis, and that is look at, again, the postmenstrual age in the neonatal period at which positive airway pressure was last used, and how much of that effect explained the motor impairment 11 years later, and it was still half, 49%, with a confidence interval between 22% at least and up to 100. Obviously not a very precise confidence interval, but the nutshell is that we believe that caffeine primarily improves long-term outcome and reduces motor impairment by reducing exposure of our preterm babies to noxious respiratory supports.
I just want to find out, the babies who got caffeine, do they go to Starbucks more as compared to the other groups at this point?
One question we have not asked. We have never collected that information, and maybe it's not so much Starbucks in children, but Coke and stuff like that. But no, we haven't asked that. But in all seriousness, there were big concerns about what this exposure to very high doses relatively to what you would get from Starbucks, right? The loading dose is 6 cups of Starbucks coffee, and some people want to drive that up even further. So there was, for example, concern that these children might have more disturbed sleep and sleep apnea and those types of problems, again, based on experimental animals. And I don't know if everybody's aware, but we did actually do a home sleep study in about 200 of the CAP trial children in the Melbourne catchment area and in the Toronto, Hamilton, Canada catchment area, and there was no negative. In fact, there was no effect of caffeine on the quality of the sleep in those children when they were about 5, 6 years old.
All right, I have time for 2 more questions. Yes, sir.
Yeah, I'm Karthik from Bangalore. A very basic question, Barbara. Does caffeine as a primary effect improve neurodevelopmental outcome, or is it secondary? Can you just tell us the hypothesis? How does it work?
Yes, so I think if you ask different people, you will get different answers to this question. There are some basic scientists and also the Melbourne group, like Stoll and colleagues, have done MRIs and have published a paper in their Melbourne cohort suggesting that the MRI benefits that they are seeing in the caffeine group are independent of the BPD effect, for example, and therefore they invoke a direct neurologic effect. But I think that data is still very tenuous, and I would agree with Alan Jobe, who recently published, I think, an excellent editorial on how he interprets the caffeine story. And he says exactly what I tried to say when I talked about this explanatory analysis, that caffeine is unlikely to be a direct brain or a direct lung drug, but that it seems to have its main benefit from reducing the exposure to other noxious respiratory supports. And sorry, Ashok, but that noxious exposure includes CPAP. So, you know, CPAP is better than ventilation and intubation, but it's still part of a noxious exposure chain, obviously, sometimes that we can't do without. So I think the corollary of that is that you should never forget that the indication is apnea for prematurity and periodic breathing. If your baby has neither, don't prescribe caffeine because it might improve the brain. There is no convincing evidence for that approach at this point in time. And remember also that there is still data that it can do harm. It's just possibly a trade-off between how much harm you reduce from exposure to respiratory supports versus how much harm you could potentially create if there is no need for respiratory support and you're just giving the drugs. It could be a similar situation to what has happened with postnatal steroids. If you give it to babies who don't, who are not destined to get BPD, you will harm them. If you give it to babies who have a high risk of BPD, you will benefit them. So it's not one size fits all.
Sir, one other short question.
Thank you so much for this talk. Do you have any comments about the dosing? In Sweden, we tend to think that more is better, and there is one academic center arguing that we should be giving not 10, but 20 milligrams per kilo.
Right. So the American Academy of Pediatrics just last year published a very good comprehensive guideline on apnea of prematurity, which I recommend, if you haven't already read it, to all of you to read. It's really a very up-to-date summary of the evidence, not just about treatment, but the whole problem of apnea of prematurity. And they very much endorse this range of dosing that we used in the CAP trial. If you're talking in citrate, caffeine citrate, 20 milligrams per kilo loading and 5 to 10 milligrams citrate per kilo per day maintenance. Yes, people are going higher. There are a couple of small trials that don't convince me that safety has been established, and one even raises the possibility of harm. So I think before you go higher, it behooves you to actually study it and make sure it is safe. That would be my response.
All right, thank you very much.